فكرة انطلقت بحزيران الماضي بلقاء مع البروفيسور شرف أبو شرف وبعيد انتخابه كنائب أطباء بلبنان إنه نخلق ريزو من عاملين بالحقل الصحي بأوروبا لخدمة اللبنانيين وصحة اللبنانيين. وهذا اللي صار بآخر أذار الماضي. خلقنا الجمعية اللي اسمها Eurolebanese Medical Society، الجمعية الطبية اللبنانية الأوروبية، تجمع أطباء أسنان، انفيرمية، صيدلانيين، كيني، وكل عاملين بالحقل الصحي من فرنسا، بلجيكا، هولندا، إيطاليا، النرويج، السويد، إسبانيا، حتى روسيا وبولونيا وغير دول كمان. هدفنا واحد، هو For a Healthier Lebanon. هذا شعار الجمعية وهذا خطة عملها، ونحن بخدمة اللبنانيين وصحة اللبنانيين بالتعاون مع زملائنا بلبنان. وموقع الجمعية على النت eurolebanese.org.
So, hello everyone. This is our fifth meeting in our series of webinars that is dedicated to COVID-19. We bring to you tonight our session regarding neurology and how SARS COV2 affects the central nervous system and the peripheral nervous system. We will be hosting.
Elle a disparu, notre amie Elsa. Ah. Élie, peut-être, ou quelqu'un peut prendre la parole.
Eh.
Ah, elle est revenue, Elsa.
Voilà.
Elle est revenue, c'est bon.
I'm sorry for this disruption. So I was saying I will be introducing tonight our speakers, which are Dr. Ivana DABAJ, who is a pediatric neurologist and who is currently undergoing her PhD in Omnics and in neuromuscular disorders. Then we will be hosting the Professor Hassan HUSSEINI, who's the head of neurovascular department in Hôpital Mondor in Créteil in France. And last but not least, we'll be having our guest and special guest, Professor Hanna MATAR from Lebanon, who will be discussing with us neuro-COVID, and who is the head of neurology department in the Notre Dame de Secours Hospital University in Byblos in Lebanon. So I will leave the microphone to Dr. Ivana DABAJ, who will start with COVID-19 in child neurology.
Thank you, Elsa. Thank you, everyone, for hosting me. So I'll be talking about COVID-19 in child neurology. I just want to add that I work in CHU de Rouen and in Garches in the Neuromuscular Referral Center. So COVID in children, we see rarely COVID in children. It has been reported as 2% of cases in China, 1.2% in Italy, and overall 5% in the United States. It can affect any age and both genders. There is no difference. The severity of the disease is usually mild in 72% of the cases. Most kids who are affected with COVID-19 are asymptomatic in almost 80% of the cases. And among these, only 5% develop clinical symptoms that are usually respiratory, or it could be multi-organ failure. In general, childhood illness is less severe than that of adults, but the exact cause is still unknown. Usually they get infected from close contact with family members. COVID-19 or SARS COV2 has infected more than 2.5 million people worldwide. There are 93 published cases of neurological manifestations, which is about 5 per 100,000 people. So is there a biological plausibility? We know that some coronaviruses have neurotropism in animal models. It is possible that the SARS COV2 is responsible of primary neurological manifestation, and we think that there is a biological plausibility. This is what we call neurotropism. So the SARS CoV2 can have neuroinvasion via the olfactory nerves, which is partially responsible for the respiratory failure. We also think that there is a possible vagal involvement, which causes the dysgeusia, dysphagia, and dysarthria, possible diaphragmatic paresis, tachycardia, and bulbar involvement. It is currently unknown if the people who have recovered from a severe COVID-19 case suffer any lasting neurological sequelae. In general, a patient that has COVID-19, the symptoms are fever, polypnea, dry cough, fatigue. The neurological symptoms that were described are headache, loss of consciousness, coma, convulsions, rhabdomyolysis, depression, hypo or hyperreactivity, and the complications are usually toxic encephalopathy or status epilepticus. These are the neurological complications. The complications in children are what we call now pediatrics multisystem inflammatory syndrome. This is a special, it's an inflammatory condition that is associated with COVID-19. It presents with fever plus multi-organ failure. It can go from different states, going from Kawasaki-like illness to toxic shock-like syndrome. There is a study that was published, it's a French study, which reported over 156 cases as of 17th of May, with 79 confirmed cases. In these patients, there was a continuum from Kawasaki-like disease to the cardiac manifestation, which is usually seen in Kawasaki, and which required ICU in 67% of cases. Simultaneously, other cases were described all over the world, mainly in Italy, UK, and New York. So the neurological manifestations in children are extremely rare. I'm going to talk about a case of an infant who's 6-week-old. He's a boy that presented with fever, cough, and a manifestation that's seizure-like, where he did 2 episodes of upward gaze and bilateral leg stiffening that the duration was 10 to 15 seconds. No shaking or breathing change or pallor during these episodes. It was not associated with feeding, and his siblings had infection with strep pharyngitis. On physical exam, he had fever and mottled appearance and slight hypertension, but the neurological exam was normal. So when they did the workup, they had positive PCR for rhinovirus and positive PCR for SARS-CoV-2 in the nasopharyngeal swab. They did chest X-ray, lumbar puncture, and the whole setup for meningitis and encephalitis, which were negative. CSF testing for COVID-19 was also negative. So they did EEG monitoring, which showed some abnormality compared to other EEG in this age. The MRI was normal. He was discharged 1 day after admission, and there were no events 1 week after. It's very common in children to see co-infection of COVID-19 with other viruses, and this is in the general cases, not only in the neurological ones. Another case is focal cerebral arteriopathy in a pediatric patient who was a 12-year-old boy with a new onset of generalized seizures, but he developed a right-sided hemiparesis and dysarthria. He didn't have any fever or respiratory symptoms, or rash or hemoglobinopathies or trauma. There are no COVID positive in the other family members. Lumbar puncture was traumatic, but it was not inflammatory. A full workup for vascular disorder was done, and it was normal, except for, of course, the brain MRI, which shows an acute infarction without microhemorrhage and a narrow bending of the proximal M1 segment in the left middle cerebral artery. So he was managed with conservative management, and upon discharge, he was hemiparetic. Patients with epilepsy, there were some recommendations by the International League Against Epilepsy and the Epilepsy Foundation, where they classified the patients who at high risk the patients who are at high risk are the patients with Dravet syndrome, which is an epileptic encephalopathy, children who receive steroids for their epilepsy, or everolimus, which is a treatment for tuberous sclerosis, and other immunotherapies. So for these patients, we should do strict lockdown. And in developing countries, due to the strict measurements of the lockdown, we think that some patients with epilepsy were deprived of continuing their treatment. Patients with attention deficit hyperactivity disorder were also affected by this lockdown. So there was a survey in France that was performed where 538 parents responded to the survey. And it was done between day 20 and 30 of lockdown. The interesting thing is that the majority of kids were stable, or there was even an improvement in their well-being, improvement in the school-related anxiety, and also there was a flexibility in the adjustment to the children's rhythm. And also parents were more aware of the difficulties of their children. Of course, this was not the case for all kids, but it was the majority. Now, talking about patients with neuromuscular disorders, there are lots of recommendations that were done. So the World Muscle Society recommends that these patients who are usually on steroids or on other immunotherapies, they should continue this treatment, because also we talked about that immunosuppressed patients are at risk, but in these cases, we should continue the treatment. So we should not stop the steroids, and if the patient needs a stress dose, it should be given. We should do a strict isolation and protective measurements, especially for patients who are on immunosuppressants, who have respiratory failure, cardiac involvement, severe scoliosis, weak cough. Prone ventilation is not compatible for children with neuromuscular disorders or cerebral palsy. These kids are usually very vulnerable to any respiratory symptom, but we don't have any data about their patients affected with COVID-19. However, we think that they are really at risk, because usually they can do acute decompensation when they get any respiratory infection. But in general, these are real survivors, and they survive critical care admissions and recover without the need for continued invasive ventilation. Concerning the treatment, we should be very cautious with the use of chloroquine and azithromycin, because it affects the neuromuscular junction transmission. So patients with myasthenia, usually it's not recommended to give them this treatment. Concerning lopinavir and ritonavir, it may cause confusion or drowsiness in children. Spinal muscular atrophy, it's another neuromuscular disorder. It's a neurodegenerative disease of the motor neuron. So these patients have currently treatments that have been present recently in the market. The first treatment is nusinersen, and due to the current situation, we're obliged to to change our practice. So usually nusinersen is given as 4 loading doses in the first 2 months, and then a maintenance dose every 4 months. And if we have a loading dose that is delayed or missed, we should administer as soon as possible a dose, and then at least 14 days after, we should give the second dose. However, it's the maintenance dose that have been missed or delayed. We should give it as soon as possible, and then continue the regimen every 4 months. It's very, very important to continue the physical therapy for these patients and continue the treatment that was recommended. Another treatment is the gene therapy. Also, even though these patients are immunosuppressed and they need steroids, we recommend that they continue their treatment as prescribed. Patients with Duchenne, Becker, or other muscular dystrophy, it's a type of myopathy, it's another type of neuromuscular disorders. These patients are on corticosteroids usually, if they are those who are walking, and they should also continue this treatment. Some patients are on exon skipping medications, and it also it's recommended to continue. ACE inhibitors or ARB for prophylaxis or treatment of cardiomyopathy, these patients should be continued. And if they have any respiratory illness, it should be taken care in collaboration with any pulmonary physician or anesthesiologist. And they should not receive supplementary oxygen without any ventilatory support. We should not prescribe hydroxychloroquine for these patients, and we should continue, of course, the standard of care for every patient. In conclusion, COVID-19 or SARS COV2 reports in children published lack the detailed information on the frequency and outcome of the neurological manifestation during the presentation and through their hospital admission. So we need more studies to better understand and to take better care of these children. Thank you so much.
Thank you very much, Dr. DABAJ, for this complete presentation. I'm gonna pass on the talk now to Professor Hassan HUSSEINI, who, as I said, is the head of neurovascular department in Henri Mondor, and who is also the president of the AMFL, Association Médicale Franco-Libanaise, who implicates healthcare professionals in France and in Lebanon. So, Professor HUSSEINI, it's to you.
مساء الخير. مساء الخير. ميرسي إلزا على البرزنتاسيون. برافو إيفانا على البرزنتاسيون تبعك. بونسوار دكتور حنا. إن شاء الله سمعني كمان. عندي ذكريات من جبال والأوزان. Que des gens venaient pour l'empêcher de respirer. Ce n'est pas le virus. Et il sentait qu'il y a des personnes physiques qu'il voyait, des hallucinations plutôt visuelles, qui l'empêchaient de respirer et qui venaient même lui couper les bras parce qu'il essayait de se défendre. Et c'est un interne en médecine et il a eu des hallucinations. Bon, il avait de la fièvre, mais quand même un tableau hallucinatoire, très angoissant pour lui. Il avait du mal à exprimer ça, de dire oui, mais je vois des gens qui viennent m'étouffer, qui viennent, et cette confusion délirium, on l'a eu beaucoup en réanimation. Beaucoup de patients décrivaient que le personnel soignant venait les intoxiquer, venait leur faire du mal, ils refusaient de manger, de boire parce qu'on risquait de les empoisonner. Donc, des tableaux neuropsychiatriques même assez sévères, et je vous parlerai de notre série qu'on va essayer de publier. Donc, l'anosmie, vous avez entendu parler, je passe sur la voie hématogène que vous connaissez, mais on pense que le virus, par l'anosmie, pouvait entrer dans le système nerveux central via la lame criblée à travers les lames ethmoïdales. Et d'ailleurs, des études italiennes, des collègues italiens ont montré que l'anosmie, on pouvait voir à l'IRM, là vous avez des coupes coronales et vous voyez un hypersignal des bulbes olfactifs bilatéral ici, et cet hypersignal disparaissait quand l'anosmie disparaissait. Là vous avez la même équipe italienne qui a montré des hypersignaux de bulbes olfactifs et c'était corrélé à ça. Dans toutes les publications qu'on a vues, parce qu'il y a eu une course quand même pour les publications, on voyait que le système nerveux était touché dans un tiers à la moitié des cas, sans parler de l'encéphalopathie, de l'hypoxie. Le système nerveux central était touché et un des signes que souvent les patients ont rapporté, c'était une céphalée, des chutes, des personnes âgées qui tombaient sans explication, et puis des AVC, c'est-à-dire on a eu des AVC, je parlerai de l'expérience de l'AVC si j'ai quelques minutes, des épilepsies, puisque Ivana est spécialisée dans l'épilepsie, donc il y avait des présentations par des crises d'épilepsie inaugurales, des atteintes des nerfs crâniens, on a parlé de la malaise vagale, mais aussi l'agueusie, l'anosmie, des troubles visuels, et une atteinte du système nerveux périphérique. Tu as parlé de rhabdomyolyse et Ivana, mais des Guillain-Barré ont été décrits. Dans notre expérience, on peut classer par catégorie. On a classé des gens par encéphalite, vraiment encéphalite, quand il y avait une méningite très importante avec une IRM qui montrait une prise de contraste qui a été rapportée par l'équipe strasbourgeoise aussi de prise de contraste des méninges et des problèmes de perfusion cérébrale. Un tableau d'encéphalopathie où le LCR est normal, mais il y a cette confusion, ce délire, ces troubles neuropsychiatriques, des crises d'épilepsie, des AVC. Je parlerai un tout petit peu des AVC qu'on a observés, qui sont différents des AVC habituels, à la fois par occlusion artérielle, mais aussi des thromboses veineuses. Et on a eu des cas de Guillain-Barré. L'AVC du Covid, c'est jusqu'à 10% dans les séries des Covid sévères. Le temps est variable entre le premier jour et le 10e jour. C'est des sujets plus jeunes qu'on a l'habitude de voir, des formes plus sévères, plus de thromboses intra- et extracrâniennes que je vais vous montrer. Vous voyez, des AVC massifs qui prenaient un hémisphère complet ou celui-là, il a eu besoin même de craniectomie décompressive, des thromboses des grosses artères, à la fois extra- et intracrâniennes. Là, vous avez une occlusion de la carotide et de l'artère cérébrale moyenne. Et ce patient qu'on a reperfusé par thrombolyse et thrombectomie, là, vous voyez le caillot qui s'est formé dans cette artère cérébrale moyenne droite, malgré la recanalisation par thrombolyse et thrombectomie, il monte dans le stroke unit et il refait, il réocclut cette artère malgré cette thrombolyse et thrombectomie. L'équipe new-yorkaise aussi a montré des cas jeunes, des cas sévères avec des scores élevés. L'équipe chinoise, la même chose aussi. Donc, on voyait ça. Mais ce qu'on a observé, et là, toutes les sociétés savantes européennes, françaises et internationales disaient qu'il y avait une chute drastique du chiffre des AVC. Les gens ne venaient pas, n'appelaient pas au départ d'appels pour AVC. Et dans plein de pays, que ce soit la Chine, les États-Unis et l'Europe, on a vu des baisses très importantes des admissions pour AVC, même baisse aussi des thrombolyses et des thrombectomies réalisées dans les UNV, et il y avait moins d'IRM demandés pour les AVC. Mais maintenant, ces patients-là nous arrivent par dizaines et dizaines. Là, on est débordé depuis un mois à peu près, où on a repris la consultation, les téléconsultations, puis la consultation présentielle. Nos services sont débordés par les appels de tous les patients qu'on n'a pas soignés jusque-là. Je ne veux pas être très long, j'ai trop parlé, je garde du temps pour la discussion. Mais bien sûr, tout le monde a envie de répondre à ces 3 questions. Je vous dis, je n'ai pas la réponse. Est-ce que ça va se terminer? Quand ça va se terminer? Comment ça va se terminer? Et est-ce que ça va se terminer? Merci de votre attention.
Merci. Thank you, Professor HUSSEINI. So I would like first, before announcing our guest and debating on these interesting points you've pointed to say that we had a minor technical problem, and this is why the discussion I will be asking our guests and speakers the questions that I got before this technical problem, but everything will be available on our channel on YouTube for the rest of this discussion. So I'm gonna ask now our guest, Professor Hanna MATAR, who is the Dean of ELMS Medical School and Sciences, and who is also the head of Neurology Department of Notre-Dame de Secours University Hospital in Jbel in Lebanon. First of all, hello, Professor.
Thank you, Elsa. Hi to everybody. Hi, Professor HUSSEINI. It was very nice hearing what you said about Lebanon, about Jbel, about Notre-Dame de Secours. I'm very interested to tell you that Lebanon is changing, and hopefully the change will not last for long. Well, hopefully. The 2 presentations were really interesting. Dr. Ivana gave us. I'm not very acquainted to pediatric neurology. I've left it many years ago, but it was very, very interesting. Thank you. Thanks a lot. and the points that were evoked were very, very helpful. Dr. HUSSEINI, thank you also for your experience, your French experience. I would like to ask a question. I'm very happy that the Lebanese experience was very, very limited, and this is maybe a success for the Lebanese government, one of the rare ones. But I'm happy to know and to see that the COVID experience in Lebanon is very, very low. So I think hopefully it will last like this forever. Dr. HUSSEINI, I'm very interested in maybe it was not in your hospital, but what about the neuroinflammatory cases? I mean by this, multiple sclerosis with the new treatments, immunomodulatory and immunosuppressant. Did you have the experience to meet them, to deal with such cases? And is there any trend in this pathologies?
Merci pour la question. Nos patients, CEP ou autres, qui sont sous immunosuppresseurs, immunomodulateurs, corticoïdes et autres, on avait très peur. On n'avait pas de nouvelles. Ils n'ont pas appelé. On suit plein de gens. On a un centre de référence à Henri Mondor, Saint-Défi et autres. Ils n'ont pas appelé. Ils n'ont pas arrêté les traitements. On les a appelés pour avoir des nouvelles. Et heureusement, il n'y avait pas plus de Covid. Ils ont respecté le confinement. Ils étaient chez eux. Ils ne sont pas venus à l'hôpital. Ils ont plus respecté peut-être le confinement que les autres patients qui ne prenaient pas ces médicaments, que ce soit les immunomodulateurs et les immunosuppresseurs. Et je touche le bois, on n'a pas eu de cas de Covid, ni d'arrêt de traitement, ni on a observé. Si, on a observé des poussées, mais est-ce que c'est le stress? Est-ce que c'est… J'ai une patiente, personnellement, que je suis pour une neuromyélite, qui était tranquille sous méthotrexate depuis des années, et elle a eu le Covid le mois de mars, et le mois de mai, elle a fait une myélite très sévère, et elle est venue à l'hôpital devant un tableau de myélite. Mais on n'a pas eu ce qu'on avait très peur, mais tu l'as dit tout à l'heure, Ivana aussi, pour les autres maladies neuromusculaires, qu'il y ait une recrudescence. Et le Guillain-Barré qu'on a eu dans le service, c'était pas des Guillain-Barré particuliers, c'était des Guillain-Barré comme post-viral, comme tout après.
Comme tous les autres.
Thank you, Doctor, for this answer. I have a question for Dr. DABAJ. Could we say with the current literature that COVID, that SARS COV2 has a different pattern than other viral infections in children, in neurology, of course?
Currently, since we don't have a lot of cases of COVID, of children affected with COVID, it's really difficult to conclude. But we know that, and also in general, children were not really affected. So the neurological cases were really very few. We have just those 2 case reports that are really not specific, and they are not very severe compared to the viral diseases that could cause more severe symptoms in children. So there is a hypothesis saying that children are spared, kind of spared from this severe infections because they have a lack in the receptor, or they have decreased in the receptor that Professor HUSSEINI described, the ACE2R receptor. So this is why the virus cannot attach to the neurological system. So we have really few manifestations.
Okay, thank you. For Professor MATAR, I've been asked whether we had data on, well, it actually joins the question you asked Professor HUSSEINI, whether we had data on how the chronic treatments in neurology, mainly in inflammatory diseases, had been pursued during the COVID-19 in Lebanon. Or did you notice anything different in your practice? Did you practice telemedicine with multiple sclerosis patients? And were there any patients who needed steroids during this period? Were there hospitalizations for that or not?
Je disais à Dr MATAR,
Oui.
On les a appelés parce qu'ils ne nous avaient pas appelés. On prenait des nouvelles par téléconsultation et quand il y a eu des poussées, maintenant on les hospitalise et des bolus de corticoïdes ont été repris. Et les recommandations, c'était de ne pas arrêter les traitements de fond, immunomodulateurs, immunosuppresseurs et autres. Et d'ailleurs, c'est intéressant parce que la dexaméthasone, on a vu que ça faisait du bien dans l'étude anglaise sur les formes graves de COVID.
The recovery study. But my question was about Lebanon. How it's actually someone asking about Lebanon, how about patients. We know multiple sclerosis is quite prevalent in Lebanon. And how did you describe your experience, Professor MATAR, during this period with these patients? So we had the French experience. How about the Lebanese one?
I would join Professor HUSSEINI in what he said about their how confined they were. I think they were very aware of their pathologies, aware of their drugs. They asked so many questions in the beginning of the COVID-19 crisis. We received plenty of phone calls about how to deal with it, how to deal with the medicine, how to deal with the virus when it arrives. We were very happy that the medication we did not have any rupture in the medication. All our patients, and I know it's we don't have figures and graphs, but we have impression that all our patients maintain their treatment. They did not have any rupture in the treatment until now. They are continuing. Maybe a little bit more of needs for methylprednisolone because maybe of the stress more than the infection. This is what we concluded in Lebanon.
Okay, thank you very much for the answer. Now, we have been hearing these last couple of days of a subject that is there truly a neuro COVID? Is it really the manifestation of this virus, or are we describing symptoms that can be found in patients who are predisposed actually to develop these symptoms, but who with the virus had triggered these symptoms and signs? So I'm gonna let you all three answer this large actually debate that is currently undergoing, and give me your insights on this matter. I'm gonna start with Dr. DABAJ.
So I guess it's the answer is difficult to conclude because we don't have a lot of data concerning the host, which is because we don't know how it acts on the host and how it's behaving. So I guess it's my opinion, but it's not based on medically. So I guess that especially in kids, the cases that were described are not, since they are not very severe, and the presentation is not something that we see either genetically or it's a malformation that could be that could appear due to COVID. So I guess for children, it's not feasible that the COVID it's secondary. It's just made it clearer, or but I don't know for the adults how the things are. But for the children, I don't think so.
Okay, then I'm gonna go to Professor HUSSEINI. So I know about your major experience in vascular neurology. do you think COVID-19 is a specificity, an entity by itself in neurology, and could it be an entity in neurology and in vascular neurology, or are we just witnessing some signs that could go in other types of diseases and patterns, but we are just now coincidentally finding them?
Elsa, c'est une excellente question. On n'a pas une réponse à 100%, mais on sait qu'il y a des formes imputables et clairement liées au virus. Il ne devait pas faire ça. C'est-à-dire que l'anosmie, les choses qu'on a vues, l'anosognosie que j'ai racontée aussi, on ne voit pas ça dans une fièvre, dans une grippe grave. Cette anosognosie de l'hypoxie, c'est un phénomène que les réanimateurs et les pneumologues nous attiraient notre attention de dire comment ça se fait, il arrive avec une désaturation si profonde, il attend le dernier moment, alors qu'un asthmatique, quand même, il appelle ou une autre pneumopathie virale, infectieuse, ils sont conscients qu'ils s'étouffent. Deuxième chose, on a vraiment vu des tableaux d'encéphalite liés à ce virus. Même si la PCR est restée négative ou quelques cas japonais ont rapporté une PCR. Mais c'est vrai que la série strasbourgeoise et dans notre série, on n'a pas trouvé de PCR positive dans le CSF, mais il y avait quand même des tableaux d'encéphalite très particulières après l'infection. Et une chose importante aussi, c'est que on a eu un délai entre la PCR positive dans le nez pour le Covid et des tableaux d'encéphalite et d'encéphalopathie. On ne savait pas à quoi c'était dû et on cherchait systématiquement la PCR qui mettait 24-48 heures avant de revenir. Donc, on a considéré que toutes ces encéphalites et encéphalopathies qui nous sont arrivées suspectes de Covid, et quand on ne trouvait pas d'autres causes et la PCR est positive, on a considéré que c'est lié au Covid, mais ce n'est pas spécifique, comme tu l'as très bien dit, Elsa. En ce qui concerne les AVC, on a eu 2 cas dans le service de thrombose veineuse extensive. Toutes les veines du cerveau étaient bouchées. Donc, est-ce que c'est le virus ou c'est la coagulopathie, comme on l'a dit, ce gros syndrome inflammatoire? Elle avait, cette patiente, des antiphospholipides qui se sont positivés, des anticoagulants circulants, des D-dimères très élevés. Donc, il y avait cet orage, mais qui a entraîné une thrombose veineuse. Et il n'y avait pas de raison, en dehors de cette infection qui était très sévère sur le plan pulmonaire par le virus, pour avoir cette coagulopathie et cette thrombose veineuse extensive. En ce qui concerne les AVC artériels, on a eu des cas de patients sans facteur de risque, ils ne sont pas cardiaques, ils n'ont pas les facteurs de risque d'athérome qu'on connaît. Et une particularité, c'est qu'il y avait des vrais caillots, souvent en tandem, en extra et intracrânien, et comme je le disais aussi dans ma présentation, souvent ils récidivaient. On les débouchait par la thrombolyse et la thrombectomie, et ils montent dans leur chambre et ils refont une occlusion de nouveau. Ça arrive, mais là, c'était plus fréquent que dans les autres cas. Donc, il y a des formes vraiment imputables et des formes où on sait que le syndrome inflammatoire et la coagulopathie ont joué. On n'a pas observé cette vascularite cérébrale qui a été décrite par pas mal d'équipes. On a vu des signes cutanés, des vascularites light, mais on n'a pas vu des vasoconstrictions partout. Et on a eu aussi un cas d'une dame dont le mari a fait un Covid très sévère pulmonaire, et elle est venue dans un tableau de confusion et délirium, et elle a fait un Press syndrome, une encéphalopathie postérieure. Le LCR était quasi normal, il n'y avait pas de virus dans le LCR, mais elle était oxygénodépendante et PCR positive pour le Covid.
Okay, so yes, this will need time, but yes, there are some specificities as you pointed out. So, Professor MATAR, what is your say about this?
I totally agree about what Dr. HUSSEINI said. I'm not very convinced about the entity as an entity. I think it's a little bit early to talk about an entity, but there's certainly a kind of tropism, of neurotropism of the virus, more than others, but I think time will tell. and when the storm is down, we will have more information, more data to conclude. Certainly, there is a kind of neurotropism, and what Professor HUSSEINI talked about is kind of more frequent and a bit more typical, but I think time will tell.
Okay, so I think you all three agree on this statement. By this, I think we have been, we're nearly. So I'm gonna give the speech now to Professor Haddad, who is the president of the ELMS, to conclude this session. And I will thank you all three of you to have given your time and experience and to be here with us. And I'll leave Dr. Haddad for the end.
اوكي ميرسي كثير. انا بحكي كلمتين بالعربي، اسمحوا لي نحكي بالعربي باللبناني. انا بدي اشكر كثير الكل اللي كانوا معنا اليوم، ضيوفنا الدكتوره دبج من روان، بروفيسور حسيني حسن حسيني، تشرفنا كنت معنا بروفيسور حسن حسيني صديق ورئيس الامافل، والبروفيسور حنا مطر صديق كمان لان كنا سوا بالجامعه، وانا بفتخر انه عم شوفك هلا معنا حنا كمان. وميرسي كثير لإلزا، يعني على طول الموديراتور هو النويو كي تيان بيان لا شوز، وبشكرك إلزا على كل هاللي عملتيه، وبعرف قد ايه حضرتي له كمان لوصلنا لهون. وشكر كمان لدكتور سعد الله تامر اللي هو ورا الكوموند، بشكر كل اللي عم بيتابعوا. وهيدي اللي رح تكون ديفيوزيه على طول على اليوتيوب على السيت تبع الالمز، ومثل اللي كانوا سبقوا، ومرتجه كمان استعدوا ل بده يكون مرتجه. السوجي هو ميديسين انترن سورتو الامبولاتوار، يعني نحن هلا خلصنا من الكوفيد، صرنا بوست كوفيد، بدنا نشوف كيف العوده على الحياه الطبيعيه والفاكسان وكله. في عندنا ضيف مهم كمان رح يكون معنا، ما رح لكم اسمه هلا، رح يكون سوربريز للكل نحكي عنه بعدين. شخص لبناني مهم كثير عم يشتغل بالفاكسان. Stay tuned. Thank you very much. ويلا à suivre. Merci beaucoup.
Merci tout le monde.